Welcome back, everyone, to part 4 of the FreedomDoc webinar series. I'm your host, Adam Habig, in association with Lean Frontiers. Freedom Healthworks proud to present the 4th installment of our direct-to-consumer medicine series. And just to reset a bit, because today's topic is really interesting, and it sounded like from some of the questions that we received, might have been a bit intriguing to a lot of you. So to level set the intent of this web series, remember, this is really about describing the impact that going back to a direct-to-consumer model or using a direct-to-consumer model applied to medical care, applied to healthcare as we know it, looking at the impact that can have and how that might be rolled out. And the first episode, we'll recap these in detail, was a little more broad-based in terms of the impact of direct-to-consumer medicine. The second episode and the third episode were very clinician-focused, kind of in the weeds in terms of some of the distinctions that we see. But this one really backs the lens out again to a wider view in terms of how direct-to-consumer medicine impacts a very critical part of the healthcare equation. So we've got a couple of great guests today. I'm really excited to hear what they say. But today's topic, building a local direct care micro network. And a lot of you had questions as to simply what is a micro network and how does that impact the direct-to-consumer medicine movement. But the subtitle there, how going direct-to-consumer removes the barriers to high-value care coordination, really hints at what we're focused on here, that coordinating care among multiple participants is critical to great outcomes and really a great consumer experience. So just to recap a bit, again, thank you all for joining us today. The FreedomDoc webinar series, a series of short lunchtime webinars really meant to educate, evaluate, help interested parties move forward. We start broad, we narrow in on subject matter, and we have interesting guest speakers. And today I know that's certainly going to be the case. How to get the most out, be sure to ask questions. We do appreciate your Q&A, your feedback. Email us after the show and tune in. And these are all provided by Lean Frontiers after the fact, so you can catch up anytime you'd like. So if this is your, if you've been with us the whole time and I see some repeat offenders in the attendee list, great, welcome back. If this is your first time with us today, this is a brief chapter and verse in terms of how the FreedomDoc series has transpired. So I mentioned that first episode, we talked about direct-to-consumer medicine in general. Look, it's a revolutionary concept that shouldn't be, but it is based on where we are today. It's making medical care accessible, affordable, and convenient again. Second episode, we talked about two variants of direct-to-consumer medicine, really concierge versus direct care, and how those differ. And then the last episode, we talked about thriving in independent practice. And that was very, very focused at the kind of the ground level for clinicians. But really the takeaway was how this is making independent medicine viable again. So today we're going to back the lens out, like I said, talk about micro networks and how direct care enables micro networks to flourish and remove those barriers to high value care coordination that often get in the way today. To recap in detail, and I'm going to move quickly, so if you've been with us before, you'll notice these are key points that we go over. But the key components, for those of you that are new to the series, the key components of direct-to-consumer healthcare: pricing clarity, convenience of on-demand services, and fully focusing clinicians on critical issues, not distracting their expertise with admin, with paper shuffling, that kind of thing. The takeaways from that first episode, really that borrowing successful innovations from other industries can help heal America's ailing medical system. We see this often, but cross-pollination from what works in other consumer service industries is critical. And adopting those best practices is really revolutionizing the way healthcare is rolled out to consumers. The second takeaway: to lower the costs, you must first know the price. We're going to see that again today when we talk about micro networks and the key to succeeding in building these. The third, under the key takeaways, eliminating barriers to access drives consumer satisfaction. We hit this one over and over again. Again, another key theme we're going to see with the micro networks discussion today is how we eliminate those barriers and watch consumer satisfaction rise. And then the fourth, and this is really an underlying thread throughout these episodes, is that insurance, it's a great financial instrument, but it's the wrong currency for most medical care. I think we'll see that arise again today in the micro network discussion. Briefly on episode 2 recap, really all you need to take away from this is concierge medicine, fantastic innovation. Direct care is the flavor that we tend to prefer because concierge still has one foot in the traditional insurance-based system. So the takeaway there, both offer great consumer service. Only direct care really offers, a complete elimination of the barriers that come along with insurance-based medicine. And then concierge prices are typically a little bit higher than direct care. Episode 3, this is mainly for our clinician audience today, but 4 major takeaways to thrive in direct care. Independent practice is again viable with this model. Be sure you know the difference between thriving and merely surviving. That's a big key that many docs trip up on, and it really affects the degree to which they find the model appetizing. Number 3, focus on the vital few, outsource the rest. Anybody from the business community joining us today is going to recognize that key takeaway. Focus on your vital few, outsource the rest. I think Dane is going to have some key points of wisdom on that point as well. Time is money. Time lost is costlier than you think. I think that's true in business, in life, in anything. But especially with focus on our direct-to-consumer medicine, time lost is costlier than you think. So again, focus on the vital few. And then number 5, no practice or business is an island. It's important that you have a supportive community, a network around you, even if you are independent, which that is a great segue into today's discussion. And we like to lead with these takeaways. So I will briefly share these, and then we're going to let our guests really expound on today's takeaways. But if you take away anything, here are your crib notes from today. Micro networks of localized, coordinated medical professionals are critical for optimal patient outcomes and satisfaction. And we're going to talk about what those are, but they are critical. High-performing micro networks involve unfettered communication between professionals, clear handoffs and follow-ups, persistent patient advocacy, and transparent pricing. Critical. Building one of these micro networks is critical to evaluating the value of care. And here's a takeaway. Large integrated hospital networks have been among the worst performers. We'll talk about why that's the case. And then 4th, when micro networks are complementary, you see quality and efficacy of care increase and costs decline. So those are our takeaways today. I want to introduce our featured speakers, and then we'll let them take the mic from here on out. But 2 great minds that approached this from really different perspectives. So it will be interesting to hear their thoughts. Dane DeLozier, our own Chief Operating Officer at Freedom Healthworks, has spent a career in the realm of really what Lean Frontiers focuses on, Dane. And I'll let you expound on that. But over 25 years in the marketplace across several different industries, finding those efficiencies that really enable businesses and entire industries to elevate their deliverable to their customers. And we're glad to have him on the show today to talk about how this impacts really his core mission. Also, Kevin Day. Kevin, welcome to the show. Community-based pharmacist in Cincinnati, really, going to show us how one of these micro networks is built and operates in a boots on the ground sense. And he comes to us from the pharmacy community. So again, a different perspective from a clinical sense, but I think you're going to enjoy what they have to say today. So gentlemen, thank you for joining us today. And I'll move right into our first slide to kind of keep the movement or keep the show moving along. But micro networks, what are they and why are they important? Dane, we'll go to you first.
Well, I in preparing for this, kind of came to this very simple idea that not only, what are they, but how they came about. The fact of the matter is they came about because that's just the way it was in history, right? You lived in a small town. There was a small community of folks that were serving each other with all their various needs, and that complementary system really worked. And what's interesting is that we kind of got away from that. And that isn't just necessarily geographically, but it still is a small group of folks that come together, each bringing their value stake, if you will, and offering their part. So I might pause there a moment. I have a few thoughts as we go, but Kevin, you're welcome to chime in as well if you like.
Yeah, for sure. Thanks so much for having me, guys. And Adam, thanks for recapping for those newbies like me to this little series. Appreciate kind of where we've been to get here. And I love having this conversation right after the one about the viability of independence. So I refer to myself and my pharmacy as a community-based pharmacy, but those outside of the world that I live in might think of me as an independent pharmacy and an independent pharmacist. And that's certainly true. So I own the pharmacy that I work in, and I'm both pharmacist, owner, clinical director, wear of many hats, as many of those in the direct care space are as well across the medical profession. So what we have stumbled into a little bit here and work in Cincinnati is this realization that I think is probably understood, but really got expanded on, of the systems being such poor houses of communication and collaboration, even when everybody in the system is supposedly under the same roof and it should be easy to communicate and collaborate, is it doesn't happen very well. And I think all of us, I'm sure, have either personal or patient stories of individuals that are beat up by the system from a patient perspective, trying to go through that care series. So the idea of direct primary care and direct care in general, where a patient can have a single person or a very, very small team to take care of most of their needs, is great, except for the fact that there are needs that individual can't take care of, right? So we take care of a lot of really complex medical patients, regardless of where they fall for the rest of their care, and are a really viable and valuable part of that patient's team. And we know that, and our physician partners know that as well. There are others who we need on our teams, right? And this is where the kind of concept grows of it needs to grow a teeny bit farther. There are often times where I want stat labs as a pharmacist, right? Because patients asking me about a new drug interaction, and we don't know, right? You can't find that out. But trying to go through the system is potentially expensive, almost for sure opaque. I can't legally send them there because I'm not a referring provider, all the issues that come up with the system. So having a small lab would be a great thing to add in, so that we can just work through these on a very patient specific and patient focused level. Every issue that comes up, if you have the right people around the team and the communication channels open, you can just blow through all of those issues really, really conveniently and be able to take care of the patients the way we all want to be taking care of our patients.
That's great. I liken this sometimes, especially for our non-clinical audience today. When I think of the idea of a micro network, the delivery of care is somewhat, there's an analogy with a supply chain in terms of what you need, when you need it for particular needs. And when you look at what you're both describing, with a direct care, kind of direct primary care quarterback, there's all these other pieces that have to fit. And that's what we're calling the micro network. And you've kind of alluded to a couple: pharmacy, labs, imaging, specialists, surgical procedures. There's all these things that have tended to, on the surface at least, to become integrated within healthcare, but that integration has not necessarily worked, as you alluded to, Kevin. And so just to kind of definitionally back up, that is my perspective of what a micro network looks like. And it's having those, that connective tissue in place without the barriers, without the misaligned incentives that sometimes, can trip up, as you termed, Kevin, the outcomes from that micro network. But is that a fair definitional description of what you see as the micro network optimized?
Sorry, go ahead, Kevin.
I was just going to say yes, so and throw it to Dane, see if he had other thoughts. So throw it to you, Dane, see if you have other
Yeah,
thoughts.
no. So yeah, definitely. And I think there's even something more deeply personal that happens in this. So when we talk about micro networks and a localized focus, let's just take, so let me back up a second. So one of the things that really got us to the real value of a micro network was some work that Freedom Healthworks is doing with CPESN. And for those who don't know it, CPESN is an organization of pharmacists that are advocating for better care. And you can go look them up and get details there. But what we've recognized is there's a journey from the physician to the wellness path to the pharmacist and back again, and probably even in some cases, as conditions may be complex, circular, right? That they go back and forth on a number of occasions. What happens is something really virtuous. They understand, they know each other very deeply. There's a better intimacy. And that is true of, yes, people who need help and have complex conditions, but it is also true of people who are healthy. In other words, they know that little community or that micro network becomes knowledgeable enough that there's even the valuable benefits of early detection, even in healthy people, of things that we, wouldn't otherwise detect in our current system. So I think what's interesting, or what we're learning really quickly, is that it just goes deeper. And these micro networks that are forming, as Kevin and I work together a little bit in introducing primary care physicians to pharmacists and initiating the micro network, there's something really virtuous that happens there.
So you alluded to this, and kind of the second bullet point on this slide, why are they so critical? We've talked about the fact no practice is an island, and these, in order for clinicians to deliver the higher value from medical care, from care delivery today, it really does involve drawing on that expertise that exists outside the four walls of their particular practice, whether you're in pharmacy, whether you're in primary care, regardless. And Dane, to your point, one of the things that we really enjoy at the direct primary care level is that that notion that a clinician who is very familiar with the patient through repeated contact and over the course of months and years is always going to be better positioned to deliver better value care, to whether it's early detection, whether it's patient advocacy, those types of things we're going to see on the next slide. But as far as the reinforcing that importance, it sounds like that extends beyond the four walls of any practice, and you need this sort of a foundational support network across specialties, subspecialties, right?
Absolutely.
Yeah, it's humbling to accept the fact that we can't do all of this, but we can't do all of this, right? Our aspects of all sorts of things for every patient and every situation where we need help for certain circumstances, and having that built in advance of who you're going to call for that help for those circumstances, even if they're rare, having it set up in advance in clear, concise communication ways is solving issues across the board.
So let me ask you, Kevin, to follow up on that. Why then, before we look at how we go about assembling these, why have the purportedly most integrated, larger networks, hospital networks, struggled? And I've got kind of the answer there, but it has to do with incentives being misaligned. But why have you seen that not work at the large hospital level, whereas direct care, this works?
Yeah, I think the incentives and misalignment there is certainly a factor. It's probably is the answer underlying, but even on a frontline level, these health systems are in the existing system, and an existing system that is at some level at least volume-based. Those frontline providers are so crushed for time, and most of what we're asking about takes a little bit of time. So if choice A is to not call me and just send 25 prescriptions without any information about a patient, and choice B is to pick up the phone for a 3-minute conversation. They don't have 3 minutes, right? Oftentimes, or at least they don't think they do. And that's where, you know, the pressure, this is where the incentive is not aligning, applies the pressure to it, but it just cuts out any sort of non-billable extraneous communication most frontline providers feel like they can't give. At least that's been my experience. And that's true for pharmacists. It's true for docs. It's certainly true for transitions of care coordinators, you know, at point of discharge. They have what's billable and what they're supposed to do. And to go that extra step interferes with their ability to do the next billable thing that they're supposed to be doing. And there's just no ability and push to do those things that are good for patients that don't have a code attached to them, or that don't have any metrics attached to them.
Whereas conversely, under a direct care model, you remove the pressure to practice by billing code, as we call it. You have more time, and really your incentive is always focused on the best outcome. And that's why I term that as in terms of value, but really the best outcome and value delivered to your patient, your customer.
Exactly.
Yeah, I would use it in terms of, you know, a lean perspective. It's eliminating non-value adding things in a process flow or a value stream that needs to happen where it's really critical. You know, Adam you alluded to it earlier about my lean background, but you know, there's a resistance or a general resistance to look at the world of healthcare like lean. Yet lean has some fantastic attributes and some amazing things to bring to all this. It is looking at that journey, that patient or that client journey, and saying, all right, what needs to happen? What doesn't need to happen? And, you know, what's waste, classical sources of waste, right? Well, they're all over the current process or system. You know, the patient lacking information at the wrong time, or, you know, not having the information they need at the right time, or seeing the wrong person at the wrong time, showing up at the wrong visit at the wrong time, right? The scheduling, extra lead time because the capacity of the hospital system isn't there, right? That, you know, that they're fairly reliant on the model, particularly that requires this 15-minute interval itself, probably means that we're not processing enough or effectively enough each time to eliminate the need for further processing later. So just to use some lean perspective in that topic, you know, you have disparate large influences with uncommon interests, if I could say it that way or be that brash, and someone needs to be looking at the entire value stream map. Well, that just really happens naturally and very, very easily when you do what we're describing here in terms of micronetworks.
Perfect. We know we want them. We know they work. We know they're great. But let's look at some of those attributes on this next slide that make them successful. And Dane, to kind of follow up on what you were saying, these are some of those touch points, those handoff points, those inflection points within any sort of a system that involves, you know, complex, multiple entities kind of working on parallel paths. I think we see a lot of these crop up. So what makes these networks successful? And I'd like to hear from both of you on this one.
Kevin, you want to go first?
Sure. Sorry, I'm typing an answer to Dr. Sawyer's question too. So maybe we'll get to both of these at the same time. To me, the success is driven by open communication and it is a biggest difference from my role as somebody not part of the system, right? I'm not owned by one of the health systems or have EMR access to be able to send direct messages necessarily easily by name to anybody across the city in the system. As an outsider to that, it's so ridiculously difficult to get clarifications, to suggest ideas, to correct mistakes, you know, everything in that regard. So if I have a patient standing in front of me that I take a blood pressure here in this room and it's 160/110, and I want to get a hold of a doc about, you know, hey, heads up, and maybe adjust the med, I'm calling probably a medical assistant who's not on site at the office and she's taking my notes and retyping them to send a message to another medical assistant who is on site at the office, who's reading her notes to convey them to the physician, who then is sending it back through that chain the other direction, right? And there's like 8 points of contact in that piece. What we've developed here in a couple of circumstances is using some HIPAA secure technology that is available outside, and I'm not going to leave it out here. It doesn't matter necessarily. There's plenty of choices. None of them are great, but like I just got the message directly from a physician to me as a pharmacist about a change in a medicine and what we want to do and a plan about how we're going to propose it to the patient. Right, like skipping the other 8 steps, all of a sudden we got to exactly what we needed to get to. So that's where I think that is the far and away best option, or most important piece to making me successful, is having that ability to communicate freely, openly, securely, and back and forth, right? Bidirectional, has to go both ways.
I think I would add that I heard quite a few sources of waste in what you just described, right? So there it is. To the employers out there, just a quick comment. What makes something like this successful? I'm going to share with the group. Maybe Adam, there's some way we can post this out to people. But I ran across recently a Journal of American Medical Association, the JAMA group, in April of 2020. It's a pretty long title, so that's why we'll post it and make it available or accessible to folks. But it's utilization and cost of employer-sponsored comprehensive primary care delivery model. And I'm not going to go into that tons. That's not what we're here for. But what was interesting to me about that was it was probably one of the most significant statistical samplings that I've run across now, where they had 23,500 folks participating. These were employer patients, and they were being, 2 groups were juxtapositioned to one another as a control group and a test group. And what they found is that strong localized care, near site, on site, the attributes of this micro network that we describe and the elimination of this waste resulted in fewer emergency room visits and fewer expensive procedures, because this your care providers, whether it's your pharmacist or the people that are a part of this network that know you as a patient, it's back to that leading indication, right? They pick up on something early and they're actually able to mitigate the risk of an emergency room visit. And so what was interesting about the study, they talk about a number of demographic groups, but some of those demographic groups are saving, by building that localized care, that they're actually driving a per head count or per capita cost down by as much as 40% in some of those groups. So it's a very interesting study, and it's the first real. I shouldn't say that. There's lots of studies out there about direct primary care and/or localized care, but it was one of the most significant statistical samplings that I had run across, and pretty compelling. And what I really loved is that they're planning to do some more studies. So it's certainly something I intend to follow.
40%. That's a big number, Dane.
Huge. Yeah.
I think we all know
all the cost we drive into that system today. No wonder we're 2.5 times the rest of the world on care.
Yeah, and I think these bullet points, in terms of what makes these micro networks successful, these are just words, and I'm sure a lot of groups will profess to exhibit these practices, but it's really not possible to the level that direct-to-consumer medicine allows these things to be manifest. And that's one thing I want to drive home. It just, the unfettered communication that Kevin talks about, the clear handoffs and the follow-ups, we say no lost sheep, being aligned so that you're always, as a clinician, a persistent patient advocate without any sort of competing incentives. And that, again, I think, as Kevin mentioned earlier, that's not the clinician's fault in the traditional system that's the case, but only by removing those distortions that occur from a third-party payer being in the middle, can you actually become a true patient advocate. And then transparent pricing goes part and parcel with that. I mean, it really, even as a clinician, as a non-clinician, as a stakeholder in this, unless you can see what things cost, it's very, very difficult to achieve a high value deliverable. That's just goes without saying. But the last point there before we move on to, and look at the mailbag, and want to keep an eye on the time for everybody, but it just reiterates what we said. Eliminate impediments and allow these micro networks to emerge. And the result, as Dane said just now, can be stark. So I'll move us along to the FAQs. And before we get into these, as we were looking at these, and we really appreciate the feedback and some of the questions in advance that people had, forgive us in advance if our answer to many of these is, well, that's something that we're working, that we do at Freedom Healthworks. Not meant to be a broken record with that, but because this is a point of critical need for clinicians in the space, a lot of these items we've identified, and there are areas that we provide solutions. So there's a disclaimer in advance, but here's a good one. How do I build one of these? We've talked about how critical they are, how important they are. How do I go about doing this?
So I'll start from the clinician kind of prospect. To me, if there are docs in whatever community that are frustrated with the way that the area pharmacies are working with them. So I taught residents recently, right? And most medical residents' concept of pharmacy is, if a pharmacy is on the phone, the only purpose for that call is, what did I screw up now? Type perspective, right? Or why do you still need this refill? I sent it already. We can flip that, and we should flip that on its head, right? There are insights that your pharmacy friends have about your patients that nobody else in the system has, because we hear things all the time because we're really close to them a lot more than most docs. The DBC docs are with their patients a ton, but I still see them a lot. And I see in their houses, we're just everywhere in that regard. So if a doc wants to build a relationship with a pharmacy, is to walk into the pharmacy. They almost always open longer than you are, so you can go without interfering your workday too much. And it doesn't interfere our workday that much. Might feel like it does, but if a doc walks in here, like, I'll drop everything to go talk to. I would drop you guys if somebody knocked on my door and said, "There's a doc here to see you," right? I would just be like, "All right, bye," like, gotta go. So that to me is that first way, and start to learn about what pharmacies do. Because again, I think from my perspective, right, is we don't do a good job selling our own services. That's on us. I think that's also true for others in the healthcare system, right? Is we don't always know what is being offered out there in the world, because we do get head down, even if we're not trying to, or really trying to do the opposite. We still get stuck in our little bubble. And you might not recognize that there are these services that are being offered around you for free or very inexpensively that might be life-changing for your patients and life-changing for your practice, right? If you can offload certain things that are not your expertise or desire to do, give them to somebody else. There might be somebody right down the street who's doing that. So to try to just find them and introduce yourself and go from there. I think as that builds up, it gets a little bit harder. And Dane, I'd love to hear your feedback on operationalizing one of these kind of into the business community and what that looks like too.
Yeah, Dane, and I've got a couple of follow-ons that might inform, kind of that next piece. But yeah. Go ahead. I'd love to hear your piece on sourcing and operationally how you stitch one of these things together, and that it's not necessarily always local, frankly.
Right. So yeah, I think my initial reaction is seek out the dissonance. Anywhere there's someone motivated to do something differently, they're probably being vocal, they're probably making themselves visible. And maybe it's just looking in some of the right places. But I love that Kevin and CPESN have done, even with us and some of the work where, we are both associations, right? We are a fairly large group each of our stakeholders, and our doors are standing wide open. So that's one way. But there are lots of informal ways. There are Facebook groups that are forming around the subject. There's quite a bit on DPC in terms of communities that have popped up left and right. It doesn't take a lot of searching to find those groups. And wow, if anything has happened over the last 18 months, it has been the world opening to Zoom and virtualization of networking. Just for myself, you know, in a LinkedIn capacity, a network that was kind of unattended to went from 500 connections to 2,000 for me over, you know, the last 18 months. Well, you know, so it's just saying yes and opening up your you know, your doors, so to speak, wherever you're communicating and where you're reaching socially. But maybe I'll stop there, Adam. I know we have some other topics we want to jump into.
Yeah.
But my key point there is seek out the dissonance. And it isn't all dissonance. Look for the people who are most vocal, and just talk to them, because they're really open. I found this community to be exceptionally welcoming, sort of being the new guy on the block.
And I love the fact, again, I emphasize that, you know, the since the world has gone virtual, and here we are on a virtual, you know, on a webinar, a virtual channel, there are avenues that have now opened up. And I know at Freedom, we're working on one that we were rolling out where, you know, you actually can connect for consults with various specialists remotely on behalf of your patients. And so there's a way that, you know, local, we're stretching the definition of local, and down the street would be great, but sometimes, you know, better value is working with someone that is not just down the street, and finding kind of a one-to-many relationship is important to unlocking those types of opportunities. I'm going to go on to number two. And you really hit on this, and maybe you can add, as a doctor, how do you network with other local direct care, really doctors and participants in this micro network world?
Yeah, to me, that's just, you know, walking in the front door sometimes, right? Just, again, opening yourself up to it. Stick yourself out there a little bit, if you know. And that, I would say that to administrators, I would say that to employers, I would say that to pharmacists, physical therapists, nurse practitioners, right? You know, I think that so much of history, you know, our current system is influenced and has been created by very naturally occurring but large forces. And you know, it conditions you to approach it in a very classical way, when in fact you have a choice every day, you know, where you choose to spend your dollars, where you choose to go network and put your energy. And I would tell you that many of the stakeholders in this community have a lot of influence. Take doctors, take pharmacists, any one of those constituent groups, take specialists. You know, as a group, there's shortages of all of them, and there's a lot of influence about, you know, how you want to do what you do.
Sure. Here were a couple of follow-ons to that. And again, we are running a bit short on time, guys, so keep an eye on the clock. Got about 4 minutes left. But any tips for, you know, professionals, clinicians who are isolated geographically, or perhaps in a rural setting where there just aren't many choices out there? And then for specialists looking to also build their own micro networks for referrals and otherwise. Kevin, any tips there?
Whoever is on the island, literally just call somebody like me who lives in Ohio in the middle of winter, and I'll probably put a pharmacy on the island. Oh, that's only mostly a good idea. So I think there's a recognition, and we sort of get to this, right? Is if you are in a physical space where it feels like an island, are you sure, right? And have you gone around all those rocks to make sure, because there are a lot of professionals that are stuck and frustrated and want to get off. So I think that to keep looking that sounds cliche, because you might be. If you're not, is to look and think about people who are willing to work with you from farther away. So, you know, we take care of patients who live very far away from here because they have a delivery driver who lives very far away from here, right? So we end up, our delivery radius is this little circle with a long spire that he can take on his way home. So we can be creative with that if we have the right places. I think a lot of people are willing to be creative for the right collaborations, and feel free, right? If we're in a direct care model, we don't have to follow the norms that have existed in the traditional care model. So if we can blow them up, let's blow them up. Again, that sounds bad, but I think we need to be open to that. I often have conversations with independent docs who are trying to do things that are very much written by the insurance companies, and we don't even realize what's written by the insurance companies anymore. So from my perspective, at least, and if we can break through those, let's break through those when we can.
Right on.
Perfect.
Yeah, jump out of the rut. It's not limited to state lines. It's not limited to, a micro network, even localized. Localized is, connected and informed, I would say, are two key attributes. And so, we've got a doc right over there by Kevin, working with a pharmacist that's just 4 minutes away from her office. And, there's specialty procedures that can be done here in Indianapolis. Well, that still is an effective relationship that can happen. And, so it doesn't have to be just within 10 miles.
So rethink your definition of local
Right.
in terms of geographic proximity. And again, I would encourage not just specialists, but even really clinicians of any stripe, plug into a network, plug into a larger network like the two that we've talked about today, or any other network that gives you one-to-many access. There are a lot of folks like you out there looking for just the same thing you're looking for. So maybe that leads the next question: best tool or methodology employed to build a micro network. It sounds like it really, there is no silver bullet here, guys. It's an all of the above approach. But again, anything you'd add to what we just said in terms of redefining locality and plugging into larger associations or larger platforms?
The only thing that I would add is to try to have a better frame of reference than I probably did when we started these conversations, right? Again, from a head down, I think I know all the answers. That's probably young blood in me too, that speaks that out. But a lot of healthcare providers have that mentality, and allowing yourself, if you're going to enter into a space like this, to be really open to ideas, and also open to the fact that this might take a while, because what you're suggesting might not line up perfectly right away with whoever you're trying to build that network with. So patience is probably actually important here, and willingness to put in some work. I mean, I'm meeting weekly with these docs in our kind of group, and have been for a year. And our work has evolved some, but it's a lot of communication about what we can and want to be doing to improve patient care.
Fantastic. We talked about non-competitive markets a bit in terms of just broadening the definition of local and working through, outside of a isolated pocket that has no competition and therefore fewer options for you. Here's a good one. How do you use micro networks to attract patients into direct care? We get a lot of questions every episode about how to grow a direct care practice. A lot of them at the primary care level, some at the specialty level, which I think specialists are finally going to be given their due in our next episode. I know we bumped that from this one, but thought it was important to build to that, talking about micro networks and how that then involves specialists. But how can you attract patients to the direct care model using a micro network? Kevin, I know you've got some experience with this that's directly on point.
Yeah, so we are very open to having conversations about why patients are frustrated with the traditional model. So when a patient wants to transfer prescriptions to me, I ask them why they're leaving their old pharmacy. Sometimes it's because they moved, and that's not very often, right? It's because the system is breaking, and what that looks like. So if there are ways that we can continue to ask those kinds of questions, whether it's about a pharmacy or a doctor or lab experience or anything in that regard, is to use those as moments of motivation for the patient and needing education about what they can find elsewhere if they know where to look. And if we have the resources to provide where to look, then it becomes this really easy, pretty patient, in like a very referred manner for patients to find direct care practices. And
so it really becomes another entry point for consumers who are fed up or aggravated in some way with the service, the value they're receiving from the traditional system. Once they encounter any touch point within a micro network, that is a great opportunity to recruit that patient fully into the direct care ecosystem. That's something I know and that's what you just alluded to. That's something that's happening today.
Yep.
I would add that, Kevin, you alluded to it earlier, that healthcare professionals aren't necessarily just naturally wired to go do this, right? And we've been suggesting this a lot. Be open to it. Go stick your neck out there, so to speak. But I find myself having conversations frequently with primary care physicians around that very subject. And it is really obvious to me, just because I get the benefit of engaging, 40, 50 doctors, over a course, that it's not a sales kind of conversation in any way. It's simply an awareness conversation that you really can choose, even if you've got insurance or whatever it is, a traditional, healthcare, you're part of a group benefits plan. You still can have a relationship with a Kevin. You still can have a relationship with your doctor. And it's not a costly thing. This very efficient model is super effective at, eliminating a lot of that waste, but also just getting a direct connection, and that alone enhances or builds a lot of value.
Yeah, any patient or consumer who sees value at any point in this micro network, whether it's pharma, whether it's a consult with a specialist that precludes an expensive hospital admission or something, that they become customers for life, and they become customers of the ecosystem that is direct care. And it's a great thing for all of us when those touch points yield more consumers understanding the value. We are out of time, guys. There was a fifth question on here that was really for me as the attorney: stark and anti-kickback implications for practices. I don't have time to really explore that right now, but the follow-on was engaging with hybrid practices. And I would tell you that if you are not dealing with hybrid practices that are still have one leg in the insurance world, then the stark and anti-kickback provisions, for the most part, don't apply and are not a concern. Perhaps a question for next time when we talk about specialists. Today's takeaways, to run through these again: micro networks are critical if we are to achieve higher patient satisfaction, optimal outcomes. High performing networks involve the unfettered communication that Kevin mentioned, the clear handoffs and follow-ups, the persistent patient advocacy, and the transparent pricing. Critical for success. Building a micro network is critical to elevating the value of care that we deliver to consumers. When these networks are complementary, things are good. Quality's up, costs are down. And direct-to-consumer medicine is the key to seeing micro networks realize their full potential. So I want to thank you for joining us today. I apologize if we ran a little bit over. Our guests were fantastic, so I wanted to give them plenty of time to expound on with their insight. Our next webinar will be August 26th, so a month down the road. And then our final, wrapping it all up, will be September 23rd. And then the first FreedomDoc conference. If you've been here before, you've seen this in the past. So thank you for joining us today. Dane, thank you, Kevin. Appreciate you hanging out with us. Thanks, everybody. Until next time, take care.
Thanks, guys.
Thanks.